Protecting Breastfeeding, a guide for professionals and aid workers supporting breastfeeding during disaster or emergency. Children under the age of 5 are at an increased risk during an emergency. Many factors contribute to this increased risk. The first and most important way providers can help mothers is to encourage and promote exclusive breastfeeding from birth, regardless of disaster risk. Food, adequate water, and shelter may be limited or unavailable in an emergency. Shelters may be overcrowded and frightening to small children. Families who stay in their homes may not have adequate sanitation or be inundated with floodwaters. Children may be separated from parents, and families are likely to experience traumatic events or images. Formula and bottle feeding increase the risk to infants because it may be hard to obtain and require mixing with clean drinking water. Powdered formulas are not sterile, and therefore a mother must also access a source to boil the water to sterilize the formula. Infants and children could be stranded, unable to access formula or water. And formula feeding increases the risk of diarrheal disease, a leading cause of infant death in the developing world. Breastfeeding is beneficial to the mother and the child. Breast milk is an important source of energy and nutrients in children 6 to 23 months of age. It can provide 1/2 or more of a child's energy needs between 6 and 12 months of age and 1/3 of energy needs between 12 and 24 months. Breast milk is also a critical source of energy and nutrients during illness and reduces mortality among children who are malnourished. Adults who were breastfed as babies often have lower blood pressure and lower cholesterol, as well as lower rates of overweight, obesity, and type 2 diabetes. Breastfeeding also contributes to the health and well-being of mothers. Breastfeeding reduces the risk of ovarian and breast cancer and can help to space pregnancies. Exclusive breastfeeding of babies under 6 months has a hormonal effect, which often induces a lack of menstruation. This is natural, though not fail-safe. This method of birth control is known as the lactation amenorrhea method and is part of promoting natural child spacing, where other forms of birth control are not available or acceptable. For a mother giving birth during a disaster, exclusive breastfeeding should be encouraged, initiated, and protected. Infants and young children can be protected from malnutrition and disease by receiving calories, nutrients, and antibodies available in breast milk. Providers can encourage moms that continuation of breastfeeding during an emergency is best for babies. The WHO says that emergencies amplify the risk of infant and young child mortality. With appropriate action, we can protect these precious lives through one of the most natural of all life-saving interventions. Providers can protect mothers from formula donations and donors who try to exploit mothers and prey on their fears that they will not produce enough milk if they are dehydrated, malnourished, or stressed. All providers and relief workers should be familiar with WHO's operational guidance for emergency relief staff and program managers. All disaster first responders should be trained to handle the unique aspects of mothers and babies. The focus should be on active protection and supportive breastfeeding. Mothers can continue to make milk even when they are dehydrated and malnourished. This may mean creating safe places for mothers to nurse and care for children instead of offering artificial milk. The World Health Organization, along with UNICEF in collaboration with the Baby Friendly Hospital Initiative, provides training courses and emergency preparedness plans. WHO has developed operational guidance for emergency relief staff, program managers. Emergencies amplify the risk of infant and young child mortality. With appropriate action, we can protect these precious lives through one of the most natural of all life-saving interventions. By understanding your population, providers can provide targeted care to that population. In different parts of the world, emergencies can be amplified by poverty, access, and remote populations. Babies are born during disasters, and women and children need to be prioritized in disaster management. The risk of dying from pregnancy or childbirth in sub-Saharan Africa is 1 in 16. Comparatively, the risk in developing countries is only about 1 in 28,000. There are currently 1.8 million displaced people in the sub-Saharan African region. Obtaining care for women who often travel long distances increases the burden on women and aid workers. Women often encounter long delays in seeking treatment, and what little care can be provided is far from adequate. Women who reach hospitals have grim prognoses, further complicated by having to travel long distances and lack of appropriate care during transfer and upon hospital arrival. Promote breastfeeding from birth. Become educated about the benefits of breastfeeding and support moms by relieving fears about not having enough milk. Partners and support people should understand that continuing to breastfeed is best for mom and the infant and should not provide formula as an alternative. If disaster happens, continuing to encourage breastfeeding and make available community support for breastfeeding mothers. Do not accept donations of formula, which can undermine breastfeeding and compromise the health of the infant. Athens University School of Medicine has outlined the following 8 steps to protect breastfeeding during a disaster. Keep families together. Create safe havens for pregnant and breastfeeding mothers. These havens should provide security, counseling, water, and food. Pediatricians can contribute using offices, hospitals, or other shelters. Assure mothers that human milk can contribute significant nutrition in the absence of safe complementary foods for the first year of life and beyond. Advocate for optimal feeding options for orphaned infants, including HIV-negative donor human milk. Assist new mothers to initiate breastfeeding within 1 hour of birth. Promote exclusive breastfeeding for 6 months and encourage breastfeeding for at least 1 year or longer. Provide support for breastfeeding through assessment of the infant's hydration and nutritional status. In situations where human milk is not available, recommend ready-to-feed formula. Powdered formula is the last resort. Use concentrated or powdered formula only if bottled or boiled water is available. Lactating women may be immunized as recommended for adults and adolescents to prevent against diseases. In conclusion, disasters can happen anytime, any place, and beginning breastfeeding at birth is the first line of defense for mothers and for babies.